Hello and welcome to the Home of Medicine podcast, a podcast in association with the European Federation of Internal Medicine. My name is a.burbridge. I'm a consultant in acute and general internal medicine in the United Kingdom. The aim of the podcast is going to be on clinical diagnoses, solving those clinical conundrums that you may have, and the all-important bit on physiology at the end of the podcast. Today, I am very happy to be joined by
me, who is Ben Lovell. I am a consultant at University College London Hospital in acute medicine and general medicine. And I do a lot of medical education work as well. And I also am the co-editor of the Acute Medicine Journal in the UK as well.
Fantastic. Thank you so much for joining us today. We are going to be recording 2 fantastic episodes. And I'm going to hand over to you, Ben, because you're going to be presenting the case to me. Thank you very much.
Oh, thank you. Okay, so I'll talk you through an interesting case I had recently, and I'd be interested to hear your reflections, thoughts, and your diagnostic skills in action. And it's the case of a 24-year-old patient, a female patient, and she presented to me on the acute medical take with a headache. And she was actually referred by the emergency department, and their referral to me was, this 24-year-old girl's got a headache. It was a sudden onset headache, a thunderclap headache. So we'd like to refer her to acute medicine so you can do a lumbar puncture to rule out a subarachnoid hemorrhage, please. And that was the referral to me. So there you go. So whenever I get a short paragraph like that or a quick referral, even I can't help myself making some quick sort of thoughts and in my head about what I could be walking into, what the diagnosis could be, even with no data. And I'm hoping everyone does the same. So I'm just wondering what flashes up to you when you get a referral like that.
Okay, so 24-year-old female, sudden onset headache, thunderclap headache, referred by ED, and they want you to do a lumbar puncture for a subarachnoid hemorrhage. Now, I have quite significant antibodies towards lumbar punctures in headaches. And we'll probably go on to discuss that a little bit later on in the podcast. But what challenges me a little bit in these referrals is that the diagnosis really has already been made, or they think they've already made it by ED, and I'm just picking up a case. Do I then go back and retake the history, re-examine and start again, or do I actually follow what the emergency department want me to do? Issues like this really do bring into a huge amount of cognitive biases into the case. And I'm already thinking, LP, sudden headache, is this a subarachnoid hemorrhage? And I guess whenever you've got cases like this, you really need to think about the worst case scenario. And the worst case scenario would be subarachnoid hemorrhage, potentially. So do we go down the route of a CT and a lumbar puncture? However, what I'd like to do is actually meet the patient, take a history and examine and sort of make my own diagnosis or my own thoughts.
Yeah, I completely get what you're saying, because there is a risk when you get a referral that I do a lot of teaching about human factors. Yeah. And there's something you call premature closure, where everyone discards the diagnosis at the beginning, at the front door, and no one rethinks or rechallenges that diagnosis. And it is quite risky. It's interesting because we're taught at medical school, when we're presenting history, we present it with the diagnosis at the end. But I've noticed that in practice, we tend to present the diagnosis at the beginning, and then we give the history explaining why that's the diagnosis, which I think probably we do because it seems more efficient. But there is always the risk of premature closure and the listener not challenging or rethinking about where else could this be. Do you want some more information?
Yes, please.
Okay, so you see the patient and you find that actually the emergency department has already done the CT head, and it's completely normal because emergency departments like to do CT heads. And the headache came on 12 hours ago, this particular headache, and the CT was performed at hour 12.
Okay.
And when you take a history, you explore the headache, and she says, actually, she's been having headaches for a few weeks now. They come and they go. And today was a particularly nasty one. And that's what everyone's focused on, this headache today that came on 12 hours ago. And when you ask her about the onset of the headache, it came on over the course of about 2 hours while she was working at a computer at her place of work. And it is a really, really nasty headache, a lot of pain. So I'll pause there for a sec.
Mm-hmm.
Does that change anything?
It does. So she's been having the headache for a few weeks. So again, it's unlikely to be a subarachnoid hemorrhage unless she's been having sentinel bleeds that are like a herald bleed pre the subarachnoid hemorrhage. She's been working at a computer. You mentioned she's been sitting there for she got eye strain. This came on over 2 hours. Again, is unlikely to be a subarachnoid because they tend to be on bam within a few seconds. The worst headache you've ever had. She's had a CT head, which she said was normal. Now, CT heads in the case of a subarachnoid hemorrhage, there's a lot of research out there, there's a lot of data, but actually they're only really useful if they're done within 6 hours. However, we do have very good CT scanners now. We're working on 3rd, 4th generation CT scanners. And if they are negative, they are very, very sensitive to picking up or not picking up subarachnoid hemorrhages. So if there isn't one there at 6 hours, great. At 12 hours, you're sort of at that grey zone, which is challenging. And that's probably why they want you to do a lumbar puncture, actually. However, aside from that, we need to be thinking about other causes of headache as well, not just a subarachnoid hemorrhage. So is it a migraine, cluster headache, tension headache? Does she have raised intracranial pressure? Does she have benign intracranial hypertension? I'd like to know a little bit more about her past medical history, about her menstrual history. Is she overweight? Does she have polycystic ovary syndrome? Is she diabetic? The list is endless. I really want to take a good full history.
Yeah, I once read a paper that said to acute medicine, 50% of referrals with inverted commas thunderclap headache, in fact, are not. Once you take a very, very specific history. Mm-hmm. And sometimes when people say, I was hit by this terrible headache today, sometimes thinking stops and the word thunderclap appears or sudden onset appears. Mm-hmm. And I like you, I detest doing lumbar punctures on people because I can see how unpleasant they are. And I've seen the side effects and the adverse effects. So I don't like doing them. So you've got to be really certain before you start sticking needles into someone's spinal cord. So obviously not the spinal cord unless you've gone horribly wrong. But giving you some more history. So she's 24, a fit and well person. I asked her, are you a headachy person? And she says, no, I'm not a headachy person. I always love that question when I'm taking my headache history. So this is a new phenomenon for her over the last few weeks. Past medical history, she's fit and well. She doesn't take any medication. She's not on the oral contraceptive pill. And she says the headache is mostly, it is holocranial. It is mostly head, but it's really focused on the left side. That is the worst side of it. And she sort of rubs her fingers against her the temporal area to show you where the worst part of the pain is on the left. And she says when these headaches first came on a few weeks ago, it would respond to paracetamol, but now paracetamol does nothing. And she's taking it 4 times a day and there's absolutely no effect. And she feels bad when the headaches come. She feels very withdrawn and irritable. She feels a bit queasy. She can't eat anything. She doesn't feel truly photophobic, but she likes to go into a quiet space and she finds it a struggle to concentrate. And then the headaches pass and she can't identify a diurnal pattern to the headache. Okay. She doesn't say, for example, they're worse in the morning. She's never actually vomited with the headache. And she's never said she's woken up at night by the headache pain. But when she has it, it is deeply uncomfortable pain. And she would describe it as an 8 out of 10 on the pain scale. Mm-hmm. Anything else you would like to know that I've missed out?
Yeah. Does she take any illicit drugs?
No, none at all. No, okay. She works in an admin and she works 5 days a week. She lives with a flatmate and she does not smoke. She drinks occasionally at social events and she does not take any recreational medication. Can I ask why you were asking?
Well, I was just thinking of, is she taking cocaine? Is she an ecstasy user? Does she use amphetamines? So a lot of the illicit drugs can cause side effects of a headache. So I'd really want to know about that. But you say that she hasn't. She lives in a flat. Is it a rented flat?
I think so. Yes, I didn't ask specifically about a contract arrangement.
The reason I'm going down that route, Has she got a carbon monoxide detector?
Oh, okay.
I'm just thinking really lateral now, thinking, okay, could this be carbon monoxide poisoning? Headache, irritability.
Mhm.
Again, it's always worth thinking about sort of weird and wonderful things. It's not up there. It's not my number one diagnosis, but it's always something to think about, to be honest.
Okay. Well, I will say I don't know is the answer, but her flatmate is not symptomatic.
Okay.
So that probably helps there.
Yeah, absolutely. Has she travelled abroad recently?
Yes, she went on a summer holiday back in July, just
Mm-hmm.
to somewhere in one of the Spanish islands, I think, but just for a beach holiday.
Okay. So there's no long haul travel?
No.
No. Okay. Any family history of any headaches?
No.
No. Okay.
No.
Okay. Has she noticed any visual disturbances when she gets the headaches, double vision or floaters?
No. She was asked about all neurological symptoms, and she does not get any sort of paresthesia or weakness in any of the limbs. She does not experience any deficits of any of the cranial nerves, and her vision stays normal. She has no auras or any visual losses. No.
Mm-hmm. Now, you did mention some temporal tenderness.
Mm-hmm.
And again, that is something that we do see in temporal arteritis or giant cell arteritis, but she's 24. So she's not really in that age group. I'm expecting her to be 50 and over, really. So to be honest, I'm going to rule that out pretty much straight away because she's a little bit too young for that. Has she had any infective symptoms?
No fever, no focal infective symptoms, no.
Okay. Any trauma, any head injuries?
Nope.
Nothing like that. Okay. Has she displayed any signs or symptoms that would suggest raised intracranial pressure? So you said that she hadn't vomited. She'd had no blurred vision, which again you can get with papilledema. Any loss of consciousness?
No, definitely not. And for what it's worth, she is a very slender girl as well.
Okay.
And she does not describe the sort of raised intracranial pressure symptoms of pain in the morning. When asked, she says, yes, the pain does get worse if she's asked to do some like vague Valsalva maneuvers. But she hasn't noticed that the pain gets worse when coughing, sneezing, leaning over before specifically asked that question. Yeah.
Okay. So at the moment, I'm still, I guess, none the wiser from in the fact that we know she's not on any, she knows she's not taking illicit drugs. You do say that she was responsive to paracetamol initially, and she's now taking paracetamol 1 gram 4 times a day.
Correct.
Okay, so paracetamol overuse.
Mm.
So that's also a phenomenon where actually the use of paracetamol can contribute to the development of headaches.
Mm. And she has been taking 4 grams in 4 divided doses daily now for about a week when she presented with this particular headache. So I was definitely thinking, even if that wasn't the primary diagnosis, because obviously the headache started before she started popping pills, has she got an element of medication overuse which has exacerbated what was an underlying headache disorder in the first place? And I see so much of that in ambulatory care and on the take, medication overuse headache. And it's a disaster for patients because it's so difficult to treat.
Now, I'm going to say something controversial now.
Right.
Has she had her COVID vaccination?
She has. Yeah, she had 2 vaccines.
And was the second dose recent? Was it a couple of weeks after the headache, before the headache had started?
The second dose was about 4 weeks prior to the onset of these symptoms.
Okay. So the reason I'm thinking that is, could this be sinus thrombosis secondary to the COVID vaccination? Mm-hmm. It's a rare complication, usually of the AstraZeneca vaccination, but it's something that I would probably think about. But again, it's not my primary diagnosis.
We certainly, in my institution, had a huge population of people presenting with headaches post-vaccination. And we CT'd a lot of them because we didn't have the data to suggest exactly how rare vaccine-induced thrombocytopenic thrombosis was. I've got to say, personally, anecdotally, we didn't pick up a single case, but we scanned a lot of healthy young people with post-vaccine headaches. And we developed a diagnosis of post-vaccine headache, which is a very vague and non-specific diagnosis. But we used that to sort of explain to the patients that that's what it was, but it wasn't anything serious, is how we phrased it to them. Did you pick up many cases of it?
So I had one particular Friday, I remember, when I must have had about 15 or 16 people come through with post-vaccine headache.
Yeah.
I didn't pick up a single one that day. And in my time, I'd never saw one.
Yeah. Me neither.
So it'd be interesting to reflect, actually how many people have developed thrombosis post.
Well, they say 4 in a million is the last data I heard. So I'm not surprised we didn't see one.
No. Okay, so what happened next?
So she had a complete neurologic examination, which was normal, and there was no meningism and there was no photophobia. She let us shine the light in her eye, and she was miserable with pain. She was clearly having a headache, but we weren't able to detect any hard neurological deficits on examination. And she actually, we gave her some symptomatic relief, some NSAIDs and a bit of metoclopramide. And we asked for a neurology consult. We have this fabulous new service at our hospital where we have daily neurology inreach to the acute medical unit, and they see a lot of headaches. And they took some more questions. And one question they asked, which I found interesting, was they said to her, "Do you get motion sickness?" And she said, "Terrible." She said, "I can't even travel to the end of the road in a car without getting really queasy. I have all my life, trains, planes, automobiles. I get really bad motion sickness." And I said to them, "Why did you ask that question?" And they said, "Oh, it's almost 100% overlap between people who have motion sickness and people who have migraines. It strongly predicts migraine," which I found really interesting. So I always ask that question now. And it was actually, what we're trying to work out with this girl is, does she have a primary headache disorder or a secondary headache disorder? We've mentioned a couple of secondary headaches. We talk about medication overuse headache. With temporal pain, I always wondered about TMJ dysfunction.
Yeah.
So is she a teeth grinder? I always put my hands over the temple and say, just chew for me. And if it clicks and cracks a bit, I think, I wonder if you've got a bit of TMJ dysfunction. So I was thinking about secondary headaches. Sinusitis is another secondary headache I see, but normally you pick that up on the CT scan. They will comment on their sinuses being packed full of mucus, and they were clear. So having not detected a secondary headache, I guess we're allowed to move on to primary headaches. And that sort of leaves us with the two big ones, which is migraine and tension type headache. And it was the opinion of the neurologists that this was a new diagnosis of migraine. And they used the pound criteria. Have you heard of the pound criteria?
I am not aware of the pound criteria.
Well, fantastic, because I get to teach now. So pound is an acronym, just POUND. And if you have 4 out of 5 of these pound criteria, you can on the spot diagnose migraine with 92% sensitivity. P stands for pulsatile. It's a pulsing pain. O stands for 1 day duration. So classically, it's a 24-hour headache that then goes away and then comes back, just like a migraine. U is unilateral, like hers was on the left-hand side. N stands for nausea and vomiting. And D stands for disabling levels of pain. So she actually scored 4 or 5 on the pound. So they were quite clear that this was a new diagnosis of migraine without aura. So we gave her some treatment, and she'd already had some over-the-counter treatment. I think we gave her 900 milligrams of aspirin. We gave her some anti-sickness. She had another gram of paracetamol. They did also believe that this was a migraine which is now complexified with a bit of medication overuse headache. And then the question, then we moved on to sort of managing the acute phase and then preventing recurrence. So we didn't admit her. I don't believe that people with migraine should be admitted. I think if you're suffering from the phonophobia and the photophobia and the noise of a migraine, the worst place to be is the hospital with the lights and the noise and the endless blood pressure taking and the blood tests and all that sort of thing. But we had to send her home with a plan. And we started on some sumatriptan, actually.
Okay. Now, I just want to go back a step.
Yeah.
Because what's really interesting about this case, and I think what as acute physicians we do well is we don't over-investigate. Now, we haven't talked about investigations in this lady.
Yeah.
Now, we know that she had a CT head. Did she have any other investigation at all done? Any blood tests?
She had routine bloods, which was a full blood count, Usinase, and a C-reactive protein, all of which were normal. Okay.
Pregnancy test?
She did have a pregnancy test. Yeah. It's interesting because she said, there's definitely no way I'm pregnant. And of course, the attitude to that is, we believe you, but we do need this pregnancy test before we do the CT head. And she got a little bit irritated. She's like, "Oh, so you're calling me a liar?" And it was an interesting conversation. That, no, we're just wondering if you could be mistaken. She's like, I can't be mistaken about whether I've had recent sexual intercourse or not. And I did see her point, and I do wonder how many other women find that a very weird thing to do when they say, "There's no way I can be pregnant." We say, "Well, we're doing the test anyway." We don't do that to anybody else, do we? In any other context where we just disbelieve a patient.
That's very, very good point, actually. And that's raised because, but then I guess on the opposite hand is if they say that there's no way they could be pregnant, and on the off chance they are, and then we've then exposed them to this huge amount of radiation. Yeah. It's a challenging one, isn't it?
It just made me think, because she was saying, I appreciate what you're saying. Listen, there is no chance. I haven't had sex for months. There is no chance I could be even accidentally pregnant. And even to that, we're going, yeah, that makes sense. We do need a pregnancy.
We still need to do it anyway.
And it was just a strange little glitch in the patient-doctor relationship, which made me just stop and think for a bit, saying, I guess maybe I should believe it. We believe patients when they tell us other stuff, don't we? We never actually do this in any other context.
No, that's a good point. And I think it's also the same when you ask about sexually transmitted diseases as well. You know, and I think it's really important that we do start to ask, you know, more patients about that. The same with pregnancy, and for some reason we don't do it very well, I don't think, as physicians.
Well, it's yeah, there's probably a way of doing it. If you've seen it done badly, then you know what not to do.
Absolutely, yeah. So in summary, we've got a 24-year-old female, fit and well, who presented with a headache from A&E, and what was classic there was the framing effect.
Yeah.
A&E sent this patient to yourselves with subarachnoid hemorrhage, needs an LP.
And you know, Amy, in other places or in other people, she would have got an LP. Yeah. She would have got a lumbar puncture.
Absolutely. And I find that very challenging because it's almost like we're being told what to do, but also it's very difficult sometimes to question other people's diagnoses. Particularly, I think as consultants, it gets a little bit easier, but certainly as trainees, as in, you know, as registrars or trainee doctors, to question a consultant's diagnosis is very difficult.
That's true. The hierarchy in medicine is alive and well. If an ED consultant referred it to a medical registrar or an intern and said needs a lumbar puncture, I think that intern registrar level doctor would find it quite tricky to say, I don't think they do. And I think most of them would need to call on their own consultant to back them up in that decision. And also it can be difficult to unpick this with the patients. If a patient has been told, you're being referred on to this team now and they're going to do a lumbar puncture, and then we arrive and say, no, you don't need that. The patient is then going, well, who do I believe? Who's the competent decision maker in this pathway that I should believe here, because I'm concerned.
And I've certainly had situations where I've gone to a patient who's been told they're having a lumbar puncture and then said, actually, you don't need one. I've taken a history. I think this is the diagnosis. And they're like, well, I want one.
Yeah.
And
so
I'm like,
I promise you don't want one.
You don't want an LP. And actually, you know, when you look at the research and the data about how useful LPs are in the diagnosis of subarachnoid hemorrhages, it is still debatable. Yeah. There is a group in America, well, in Canada actually, who have developed the Ottawa score.
Oh yes, I love it. The Ottawa score, I love it.
Yeah, which is, again, it's still not been picked up very much in the UK. No. And that tends to be used in people who are under the age of 40 with sudden onset thunderclap headache. Yeah. And it looks at if you had loss of consciousness. If you have, you can't rule it out. Yeah. Are you over the age of 40? If you are, you can't rule it out. And it's basically like the PERC score or the pulmonary embolism rule out criteria. It's very similar in that it either rules in or rules it out. Yeah. I find it really useful, actually. But
very
again,
for young people, because as you say, one of the cutoff criteria is their age. But for young people, I find it very useful, not only to help me with my decision making, but then to defend my decision making when I'm writing the notes, saying the history is not so in keeping with the subarachnoid hemorrhage. He scores 0 on the Ottawa score, and it just helps other people then follow my mind lines and my clinical reasoning a bit later, and supports the diagnosis or the decision that I make not to do the LP, because I can't even remember the last time I did an LP for query subarachnoid.
No,
you can usually rule it out on history and examination.
Absolutely. I completely agree. And I'm sort of like a one woman band at work trying to get people to not do LPs. It's
Well,
like,
I'll
oh,
join your band. I'll join your group.
thank you very much.
I'm
And I do often back it up by research. And
Yeah.
what's interesting is in the UK, there is still very little guidelines on do we LP for subarachnoid hemorrhage. The only one I can find still is the Royal College of Physicians 2015 guideline on stroke. And it says that if you have a headache, you only do an LP if your GCS is less than 15.
Wow.
So this sort of historical usage of LPs in subarachnoid hemorrhages to diagnose it, actually, where has it come from? Where has this guideline come from? Because there isn't one in the United Kingdom.
Yeah, and I don't want to underplay, obviously a subarachnoid hemorrhage is a devastating diagnosis.
Absolutely.
With significant mortality. And, very rarely people do get them. And we shouldn't, I'm not saying people should listen to me and you talking and say, oh, I'll never do an lumbar puncture again.
No.
Even if someone scores 0 on the Ottawa score, and you can still use your own clinical judgment to do it. But to me, I rarely get to that point in my, just speaking historically and anecdotally in the decision-making process for the reasons that you say. You can usually argue against it quite nicely from the history you say. I mean, who comes in with a decreased GCS with a headache? I mean, practically nobody. That's an interesting...
it is, isn't it?
Information,
yeah. And there was I read an article by the British Headache Society, and they said basically since COVID that actually we shouldn't be doing LPs anyway on people who have a headache, and that we should be utilizing CTs within the 6 hours. And if we still really think this is a subarachnoid hemorrhage, we need to go to CT angiogram.
Which is an interesting conversation with the radiologist, isn't it? But,
absolutely.
I mean,
yeah, I could talk about this for hours, but I won't. Okay, so we've got headache, we've got primary headache disorders and secondary headache disorders. So for our listeners, if we just list the primary headaches and the secondary headaches.
So primaries, the ones I'm thinking of are the common ones, migraine and tension type headache. And it's always, you should always explain to the patient, tension type headache. Tension means that it's a tense pain. It feels like tension on your head, because you'll say you've got a tension headache, they go, but I'm not tense, I'm not stressed. I think you mean psychologically. So those are the big ones. The other primary headaches are the rare, exciting ones like the cluster headaches, the autonomic, trigeminal autonomic cephalalgia headaches, so cluster and sunct and sooner and that sort of thing. So they're the big primaries for me. Big secondaries, we've mentioned them, I guess, subarachnoid, medication overuse headache, sinusitis. You mentioned temporal arteritis, giant cell arteritis, trauma, raised intracranial pressure, idiopathic intracranial hypertension. So those are the big secondary ones, I think, that we see in acute medicine.
What about malignancies? Do you see many brain tumours presenting as headache in acute medicine?
Maybe one a year. Yeah. And usually I find they don't present with just headache. They tend to have other things. I think I'm speaking completely anecdotally now, I'm not backing this up by any evidence, but I feel like most of the time when I make a new diagnosis of a new brain tumor, they've come in with a fit, with a seizure, or they've come in with hard neurology, like I've suddenly got foot drop, or I've lost power down one side, or something like that. I really can't think of the last time I saw a patient who came in with just a headache, insidious headache. But of course, if someone does come in and say, I've got a worsening headache over several weeks and I've thrown up with it and it's worse in the morning, and then of course we want to rule out a space occupying lesion, but it's very rare that it just turns up, in my experience.
Yeah, I agree. I've had a few over the course of my years, but it's not something I see regularly. But it's often the thing that patients are most worried about.
Yeah.
And often it's about allaying their fears. And often I have done a CT, rightly or wrongly, whether you would agree with this, in somebody who was very, very anxious about having a brain tumour.
So you're talking about the therapeutic head scan. Listen, I'm as guilty of it as you are. I mean, it depends. If there's radiologists listening, they're probably fuming because they think this is not how we should use our resources, nor our radiation on healthy people. But I've got to say, sometimes it is the most useful therapeutic thing to do, and I have done it. I'm hoping there's a falling in line behind us and saying,
yeah, I think we're all guilty of doing it, particularly if you've got a frequent attender, very, very anxious, and you've tried everything.
Yeah.
And it sort of is like the last line. but you know, it can be helpful, and I'm not saying that it's the right thing to do, but actually sometimes it's the right thing to do for that
Yeah.
patient at that time. So it can sometimes work. So this patient was diagnosed with a migraine, and what was
Mhm.
interesting was the link with motion sickness.
Yeah, which
That
is
was
a learning point for me as well. But he said, the neurologist said to me, ask your migraine patients if they get motion sickness. I promise you, like 100% of them almost will say, oh
gosh.
yeah, really badly, yeah.
So from an acute setting then, if we do have a migraine, how would you treat that patient?
In the acute phase,
Mm-hmm.
well, standard stuff would be basic analgesia. So a gram of paracetamol. You can give 900 of aspirin, which nurses find absolutely bizarre because they're used to
It's a
giving,
huge.
yeah, they're like 300s. And you have to say, I promise you this is the correct dose. And when they count out all these pills into their palm of their hand, they're like, are you sure? But we are sure. Or you can give them an NSAID, such as 500 of naproxen I like. I've given 50 of diclofenac before. And I think the number needed to treat to get one person pain-free is about 7 or 8 for those. So they have got some good efficacy. Do you give IV fluids? I wouldn't cannulate someone specifically, but a lot of people arrive to me with a cannula in situ, and I don't have a big problem. I mean, if you have a migraine for several days, you probably are a bit dehydrated because maybe you've been vomiting, maybe you've not been eating or drinking. And we do know that dehydration is a trigger for migraine. So I don't have strong feelings about giving a liter of Hartmann's or something at the same time. But I think the evidence for it is actually quite mixed. The specific treatment is your triptans, which you can give sumatriptan, you can give it orally. I'm more familiar with sumatriptan because it's been around the longest. But you can give, sumatriptan 50 milligrams orally. You can give as an intranasal spray if they're vomiting too much to keep it down. Intravenously, 6 milligrams I've given before. And I think about 50% of people tend to respond to a triptan quite nicely. One thing I never give is opioids.
Okay.
Because I do know there's a lot of evidence that opioids are actually very bad to give in an acute migraine attack. They perpetuate the nausea and vomiting. They're terrible for causing medication overuse, headache, and they precipitate bad outcomes. And there are a wealth of systematic reviews saying that opioids should not be used in migraine. You can go to the BASH, the British Society of the Study of Headaches. They say do not give opioids for headache. It's difficult because sometimes they arrive from the ED with a bit of tramadol or a bit of cocodamol on board already, but it does predict very negative outcomes for these patients. So I do try and stay away from those as much as I can. And that's my acute phase, really. One good tip, which I will pass on, is if you're going to give any medication orally, even if they're not vomiting, give it with metoclopramide, a prokinetic, because when they're in the acute pain phase of a migraine, they don't absorb. They have gastroparesis, so it will just float in their stomach. So anything I give them, the aspirin, the paracetamol, or what have you, I always give it with some oral metoclopramide as well, just to facilitate absorption of the drug. And I think that works quite well.
That's a really useful tip. Have you ever used high flow oxygen as a treatment for acute migraine?
Never. I've used
No.
it for trigeminal headaches before, but I've never tried it for migraine. Is it effective?
Well, it was something that I read, I mean, it was a few years ago now, that people would utilize high flow oxygen for the management of migraines. It's not something, again, that I've used, and it's clearly not something that, is commonly used anywhere else either. So
No, I've never heard of that one.
I've probably just made it up. No, no, I
Well, it's a
haven't.
nice, harmless treatment to give, isn't it, with no side effects? So why not?
Yeah. Okay. So, more chronic management of migraines, I guess, is sort of beyond what we would do. But
Yeah.
patients who've come in with migraine, they often on a beta blocker potentially.
Yeah, I've started that before actually in ambulatory
Yeah.
care for people who say, like, especially for people who say, I get a migraine once a month, it's a menstrual migraine, I know it's coming, and I miss 2 days of work every month. Then I have before started them on medication. I quite like, I know it's a dirty old drug and no one else likes it, but amitriptyline, just 10 milligrams at bedtime and titrating up. I'm quite cautious about amitriptyline in anyone over the age of about 50. And I do like to see an ECG beforehand, but
Okay.
yeah, I find amitriptyline quite nice, and it helps people with their sleep as well. But younger people, I've given propranolol before, 80 milligrams, modified release, and say take once a day.
Okay.
And I know that neurologists are very keen on topiramate, which obviously requires a lot of careful conversations about, contraception at the same time. So it's very, very teratogenic. But I've never started topiramate. I feel that's slightly outside of my skill set as a acute physician. The other two, and also, have you heard of riboflavin?
Yes.
as a thing. So that I've noticed that's just appeared on neurology plans now, 400 milligrams riboflavin daily. And I think there is some evidence to support that as a prophylaxis, which I don't know why or how, but it seems to be.
Yeah, it's interesting, isn't it? That, you know, even there's so many new medications that are always coming out that you really have to keep up to date, don't you, on them? So where would you go if you wanted to find more information about migraines? Is there a particular site that you utilize?
Yes, and it's actually for patients, and I always signpost my patients towards it, because a lot of having migraine or any chronic illness is about patients owning it and being able to take a role in managing it. So I always signpost them towards the Migraine Trust website, migrainetrust.org. It's fantastic, but it's also really good for physicians as well, because it gives you all the latest data in a really easily understandable way, because it's written for patients about what has evidence and what doesn't have evidence and what your doctor might give you. And it's just so useful. So I always signpost patients to that. It also gives them loads of really good advice about sleep hygiene, common triggers to avoid, how to keep a headache diary and why. So I find that very useful for them, but I also love dipping in and out of it.
Okay.
I use Up to Date a lot as well in the UK.
Fab. So what I'm going to finish now, but what I want from you before we go is your 3 key learning points that you want our listeners to take away from today's podcast.
So number 1, beware referrals for lumbar puncture. If you're going to do the lumbar puncture, you have to be absolutely certain you want to do this invasive procedure with known adverse effects for good reason. So always go back and take the history carefully again. Use the Ottawa score, use the 6-hour CT data to guide your decision making, and don't take the decision lightly. That will be number 1. Number 2, I think that nice little pearl about motion sickness. I'm not saying everyone who gets car sick has got a diagnosis of migraine, but it's I just found that a really interesting little nugget that I take forward and use quite a lot now and ask. And I guess the third one would be the metoclopramide one. So any oral medications you're giving to an acute headache sufferer, give it with a prokinetic, because it will facilitate absorption and make the onset much more speedy.
Absolutely fantastic. Thank you so much. And I think I would like to, I guess my key learning point is to remember that your cognitive biases and that framing effect of that referral from the emergency department, from the headache patient with a subarachnoid hemorrhage, re-question that. Take the history, examine the patient. Osler said, listen to your patient. They are telling you the diagnosis. And often we can make a diagnosis from a really good history.
Agreed.
Rather than relying too much on these invasive investigations like a lumbar puncture. Fab, thank you so much. That was really, really interesting and useful. And I have learned about the motion sickness. So that's a brilliant one. I'm going to, that's my takeaway point from today. Thank you so much for listening to this episode of the Home of Medicine in association with the European Federation of Internal Medicine. You've been listening to Dr. Amy Burbridge and Dr. Ben Lovell. Thank you so much, and we will see you on the next episode. Goodbye.
Bye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.